cyst and fibrous dysplasia, and we have published this paper in CORR. No, this doesn't collapse. No, it's a strong bone otherwise. And in cyst, you see the neovascularization starts from inside. You just give support if required, but if the good bone is there in the head of the femur where you can seed your implant, you don't require any curative or bone graft or any addition. Yes, that's what I'm saying. You place the fracture at right angle and this heals. We have done 7 cases and now we have follow-up of 14 years.
I have one question. One of the slides you showed that the intestinal fragment is medialized.
Yes. It will give support from below. That was in fibrous dysplasia. You support the head because there is a fracture of the neck. So it is support is from vulgarization and medial buttressing.
Otherwise you lateralize the fragment.
If you find that the knee can be under stresses, then normally you should lateralize it. By 1/3 of the, normally you should lateralize
The
it.
second question is that I've done at least 3 hips with a new synthesis plate, the principle of which is almost similar to the plate plate. It's a fixed angle plate. You don't require to remove a wedge. And I've done 3 cases. One is
The new plate which has come by synthesis,
The principle remains same.
so that opens the wedge medial side. That opens it.
Without a wedge removal.
Yeah.
My question is, can you do away without a wedge removal?
We can do it with wedge removal. That will open it from the medial side. But you see, we are not happy with that implant because you cannot lateralize it. And whatever they say lateralization, in fact, this is the whole of the femur and patient is going to have a limp. I have told these synthesis people that this is not a good implant. The double angle implant is the best implant. But you have contained the head very well into the socket. The angle was initially 70 degree. So this is just near normal angle. So there are no in fact stresses on it. Stresses will be there if excessive angle is there more than under 40 degree.
Thank you very much, Dr. Magoo.
Thank you.
We will invite the speakers again at the end of the session for some more questions and answers. In the meantime, there is a slight change in program. Dr. Sandeep Vaidya is here. Dr. Sandeep Vaidya, please. He is going to speak on slipped capital femoral physis. Yeah, with emphasis on open reduction. It's not going to be a debate. He's just going to give a talk.
Okay, so my brief is actually to give you a brief overview of the safe surgical dislocation. I won't go into the technique because that was not intended to be the original talk. But SCFE, now as we know, SCFE is an adolescent hip disorder. It is characterized by a varus and retrograde slippage. Now, when we talk about treatment of SCFE, the treatment is essentially surgical, and there is no controversy about that. There is no role of conservative management in SCFE. But when we talk of surgery, what is the optimal surgical modality? And there is a lot of debate going on about this. Okay. What we know definitely that close reduction is definitely out of question, because what happens in the slipped capital femoral epiphysis is as the femoral head slips, gradually the vasculature which is on the posterior aspect of the femoral neck in the retinacular blood vessels, they get contractured, and then if you try to do a forceful close reduction, this vascularity will get avulsed and you will land up with an AVN. So in that case, what are the surgical options available with us? There are mainly 2 surgical options available. One is an in situ pinning. That means you don't reduce the slip at all, you just fix as it is without attempting a reduction. That is one option. The other option is the Dunn osteotomy. The Dunn osteotomy is nothing but it is a cuneiform neck shortening osteotomy which is performed at the head-neck junction. And by this it facilitates an easy reduction of the femoral head on the femoral neck without placing any stretch or avulsing the vascularity of the femoral head, and so AVN is prevented. Originally, Dunn osteotomy was described by the anterior Smith-Peterson approach, but Gans modified the Dunn osteotomy and described it by the safe surgical dislocation approach. Now, the safe surgical dislocation approach is an approach which is again described by Gans based on his study of the vascularity of the femoral head. And in this approach, basically the hip is surgically dislocated after elevating extensive retinacular flaps so that the vascularity to the femoral head is protected and there is no AVN. So, if we now talk about which is the better surgical modality, it is the in situ pinning or it is the modified Dunn's osteotomy, there are four main questions that I would like to ask myself if I want to answer this question. So question number one is, does modified Dunn's osteotomy achieve fascial stabilization and prevent slip progression? That is the first query. And if we look at the literature that is available and the series of on the modified Dunn's osteotomy that have been published to date, we can see that there is not a single instance of slip progression. So definitely that modified Dunn's osteotomy achieves the first objective, that is it achieves fascial stabilization and prevents further progression of the slip. Now coming to the second question, what about the technical feasibility of the in situ pinning in moderate and severe slips? And here I would like to give you an example. Now this child has a left-sided mild SCFE. And I would say that an in situ pinning is certainly technically feasible in this case, where the child has a mild SCFE. But then on the contralateral side, on the right side, the child has a severe SCFE. And in this case, the in situ pinning would be technically very difficult. Number one, your screw entry point would be very much anterior, close to the femoral neurovascular bundle. Number two, your screw trajectory would be pointed awkwardly posteriorly. And number three, you would have a very flimsy hold in the proximal neck fragment. So I would say that whereas in mild SCFE, an in situ pinning is definitely a feasible option. In the moderate and severe SCFE, I think the modified Dunn's osteotomy scores over the in situ pinning. Question 3 I would like to ask myself is, does the modified Dunn's osteotomy reduce the rate of AVN? And this is a very important question because AVN is the most common complication which which really spoils the result in an SCFE. So if you look at Randall Loder's review article and we look at the rate of AVN in an unstable SCFE using the in situ pinning method, then we see that the rate of AVN in the traditional treatment method is about 21%. Compare that with the 8% AVN rate seen with the modified Dunn's osteotomy. These are all the papers on the modified Dunn's procedure that have been published so far. And definitely here we can say that the modified Dunn's osteotomy is definitely a promising surgical procedure which promises to reduce the rate of AVN in a case of an unstable SCFE. Last but not the least, does a modified Dunn's osteotomy reduce the rate of osteoarthritis in the long run? And herein you have to understand what is the patho-anatomy of the osteoarthritis in case of an SCFE. So in case of an in situ pinning, what happens is you are leaving a residual deformity at the head neck junction. You are not correcting the deformity. Now there are some papers which say that this residual deformity gradually can remodel on its own over a period of time. But there is still not clarity on how much of a deformity, how much of a severe slip remodels on its own, and also what is the influence of age on this remodeling. Okay? Anyways, even if the uncorrected deformity is left uncorrected, it will lead to a femoroacetabular impingement, which will eventually cause labral tears and cartilage delamination, and eventually osteoarthritis in the long run. So if you look at the literature that is available, the evidence that is available, we have evidence that in moderate to severe slips, there is a 60 to 100% osteoarthritis on long-term follow-up. But not just in moderate to severe slips, there are recent reports that even in mild slips, there is radiological evidence of osteoarthritis on long-term follow-up. How much of this radiological osteoarthritis translates into functional disability and clinical osteoarthritis, we still don't know. So that is still an unanswered question. Additionally, if we have surgeons' descriptions where the surgeons have operated mild slips by the safe surgical dislocation approach, and even in mild slips, the surgeons have noted cases of labral tears and full thickness cartilage delaminations. Now these reports give credence to the thought that even in mild slips, if they are not realigned, if the deformity is not corrected, it does lead to osteoarthritis in the long run. On the other hand, in a modified Dunn's osteotomy, it creates an anatomical realignment, so obviously there is no head-neck junction deformity, so obviously there is no FAI and there is no risk of osteoarthritis in the long run. My personal experience, I will just give you two examples. This is a case who presented with an unstable slip. We treated him by the safe surgical dislocation approach. The hip was dislocated by the technique described by Gans. These are the post-operative X-rays showing good capital realignment. And finally, an X-ray at 2 years follow-up, and you can see that there is no evidence of osteoarthritis and he is doing quite well. Another case, now this is a bilateral SCFE. On the left side, he has a mild SCFE. On the right side, he has a severe slip. We decided to do an in situ pinning on the side of the mild slip. On the side of the severe slip, we corrected it by the safe surgical dislocation approach. And now it is almost 9 months follow-up, and this child is complaining of symptoms suggestive of impingement on the side of the in situ fixation, but there are no such symptoms on the side of the safe surgical dislocation. So with that, I end my talk, and I conclude that the safe surgical dislocation is an effective way of managing SCFE. Of course, there is a learning curve involved, but if you counter that learning curve, I think it is a very promising treatment modality in SCFE. Thank you.
Thank you. The meeting is open for discussion with Dr. Magoo as well as any questions for them. If you may have, please feel free to ask them now. Can I ask something from Dr. Magoo? Now that the house is silent, maybe I can get the ball rolling. I'm not aware of Sandhu's classification on AVN. You mentioned it.
It is 1, 2 and 3.
Acha.
When there is avascular necrosis, it is 3.
Okay.
And the gap is of more than 2.5 centimeter, it is 3.
Okay.
The neck is absorbed, it is 3.
Okay. Okay, sir. And I think in your talk we saw very nice osteotomies. We saw very average implants, but that just goes on to show you that implants are not important. It is the technique and the principles of the surgery that is more important. But curiously, I just was wondering, when you bend the plate, do you get any fractures at that bent area during the course of healing? Do you get any problems?
So firstly, you have to calculate the length of the implant, because the contour plate are not available that time. Now we are getting it, or we are getting it customized. So on a double angle, standard double angle implant, you take a thread or a wire and measure the length. So you get the length of the separate plates, and over it you bend it. So this doesn't break, but the contouring is not excellent because it is a C-shaped type of that.
All right.
It's a weak implant, so can be used in children. That's why we always supplement it with a
Hip spike. Yeah, I thought so. I thought so. Dr. Vaidya, just questions to you. You mentioned the good results with Gans safe surgical dislocation. However, it is also now slightly common knowledge that the results from Gans in preventing AVN are not replicated by other surgeons who have carried out these procedures. You very nicely mentioned all the people who have done these procedures and they have low AVN rates. But even in your charts, there is a surgeon, Hubert, I think he has 33% AVN rate. And we were just looking at a large multicenter trial by Shankar. And overall AVN rate is 26% in those. So actually, if you do this procedure and you are not well trained in it, or maybe even if you just do this procedure, you may bring more harm because AVN rate actually rises compared to the natural history. What do you have to say to that?
I don't think the AVN rate rises. What happens is, in an unstable SCFE, even in the series that have been described, the rate of AVN ranges till about 40%, even in the cases treated by the traditional methods. And traditional methods means we are talking about incidental reduction and in situ pinning. See, what happens is there is some amount of AVN rate that is going to persist because that is a part of the natural disease process in an SCFE, in an unstable SCFE. If you go according to a statement by Randall Loader, with the treatment modalities currently available, AVN is never going to be a never term in SCFE. But what I am trying to say is there is no evidence to show that safe surgical dislocation creates an iatrogenic AVN. Probably all this AVN that we are seeing are part of the disease process itself, and unstable SCFE is known to have that AVN rate.
Unstable HCFE that is treated.
I don't see those kind of AVN rates when you are doing Dunn's osteotomy. Not only does do a Dunn's osteotomy, what you is trapezoidal. What you basically release is the, what you remove is basically the fracture callus. Callus that forms in the area of the neck, which is preventing the head to come back, close back. And since you are always anterior, you go posterior, the posterior capsule remains intact. You continue to remain intact. So really your avian rates are not that bad. We do have
in
avian.
the GAN series, in a follow-up of 7 years, in about 100 cases, he has said that he has not seen
Any avian.
any avian. But he himself says that this procedure is extensive. This requires blood transfusions, and this still requires skill of lifting the flaps, keeping. You should be above the region of the nasopharyngeal so that you are not able to damage the ascending vessels of the.
Well, in all fairness, I did speak to Thaddeus Longo about it, and he said that because people are doing these procedures without receiving training by us, that is the reason they get avian, and we don't have avian. So just
make sure that you will not have any growth plates still when you remove the callus.
No, we want the growth plate. We want to curate the growth plate.
So
We
you
want
have
to that to
remove the
close.
growth
Yeah.
plate. No, sir, the
No,
idea
we
is
want the
remove
growth plate to close.
So
You
that
have to.
fusion occurs.
the other thought is, does anybody know if you get avian in an untreated SCFE?
No, you don't get avian in an untreated.
So natural history
No,
of
no, but-
SCFE is not to have avian.
No, no.
And when you get 26% rate.
Here I
that
would
is
like to
from
differ. You see, in all the series that have been published thus far on the modified Dunn's osteotomy, the rate of avian in stable SCFE is 0. All the series, not just GAN series, all series. This is only about the unstable SCFE that, we are talking about the avian rate. So, an unstable SCFE, there is no question of leaving it alone because the child is not able to bear weight on that limb. It's like a fracture. It's like a Delbay 1 fracture through the physis, through the SCFE that is happening.
Doctor, when they actually are going to do the Dunn's or GAN's procedure in unstable only. I don't know if I've never done it for stable.
No, but
So that's the thing.
no, but what would you do in a severe slip? That is the point. Mild slip, agreed. I mean,
Even
it
severe
is.
stable slips, I pin. I have no problem. It's not at all tough. And
And what about the residual deformity?
We've had long-term. This is anecdotal, of course. It's not a published series, but long-term results, nobody has any problem.
And for the avian which develop in Dunn's, I can say that for Dunn's, they are very regular. About 12 cases in the last maybe 5 years. There is an element of avian, but it heals. With time, you follow the skills, it heals. Yes, there is a child who has one or two trochanter, one or two. Then the age at which
Well,
it happens, it just heals.
Well, I would give it to you. See, the only difference between Dunn's and modified Dunn's is the approach. The point that Gans says is against Dunn's is, you are not really having access to the retinacular flaps. So you don't know really exactly how much wedge you want to remove. So, if by chance you are technically not so sound and if you remove a lesser wedge than needed, then while reducing it, you may, inadvertently, whereas in the safe surgical dislocation approach, you have a 360-degree access to the femoral head. You are raising the retinacular flaps. So there is no question of, avulsing that. That is the only point, But
The other thing, Dr. Sandeep, is you spoke about the deformity which is residual after in situ pinning versus a modified Dunn where you have no deformity and that gives your hip a longer age group. With a lot of studies where they've done THR on patients who have had SCFE, and they found that the primary cause of secondary osteoarthritis is avian and not the deformed head at the time of healing.
So that's
It's
also a
avian which
thought.
causes the secondary osteoarthritis.
That's also a thought.
okay, but there are some long-term studies which suggest the other way around also. There have been cases of osteoarthritis which are not related to avian. I mean, they have not undergone avian, but it's basically because of the FAI and the the labral tears and the cartilage delamination. There's a lot of literature which has come in recently about that, which leads to OA in the long run. And long run means we are talking about 30 years, 40 years. Of course, with the modified Dunn's is still a new procedure, so we don't have that type of follow-up. But we have reason to believe that since we are eliminating the deformity, this won't happen in the long run. That's the hope. Let's see.
Any more questions, please? Doctor. Sir, what was the question?
Ossification of the femoral head occurs very well.
Varus containment osteotomy.
Ossification of the femoral head occurs very well with containment osteotomy. You just do a varus osteotomy, continually make it 90. Head containment is good, and gradually with the age growth, as the child grows, the varus starts going into vulgarization, and a near normal neck shaft angle you achieve by the time he is 14 years of age. The only thing is that you have to remove the implant, because implant starts migrating distally, and the blade part this starts cutting the neck of the femur. So there is no limb, patient has no pain, and one of my patients is now playing in the national badminton team. He's a member of that, and I think he's doing very, very well. So in my initial cases, I converted varus into valgus once osseation was complete, but now I have stopped doing it.
Sir, is it true for all the age groups or a little younger age group?
Younger age group give you better results.
Because,
See, up to
I feel
6, 7, it's fine. And
what the-
otherwise, it will late onset and then
perhaps the remodeling may be a little less.
middle.
I have a question for Dr. Magoo. Sir, do you do trochanteric physiodesis at the time of your osteotomy?
No.
You don't. So is trochanteric overgrowth a problem in your cases? No.
With vulgarization, in fact, the trochanter goes away from the ileum.
He's talking about
No,
Perthes and
Perthes and
Perthes and varus.
No, it's not. I have some cases with me. I
it's
can
not a
show you later
problem.
on, It's not.
It's not a problem.
It's not.
Dr.
John wants.
John.
Regarding this safe surgical dislocation for SUFE, it was interesting because in the last AO pediatric fracture course, we had a bit on this, and Dr. Slongo was there, and I showed him some of my cases which we had done and the operative photographs, and what he commented was, what you do for the SUFE is different from the traditional Gans osteotomy for safe surgical dislocation. Okay, so you actually need to take off a little more of the trochanter than you do in the adult hip dislocation, where you actually try to leave a bit of the tip of the trochanter in the stable part. The second thing is the osteotomy is very distal. We tend to make at the neck, so you actually are going almost onto the physis with when you're taking out that bone out, whenever you're doing that osteotomy. When it's callous, you take that out when you're doing the osteotomy. The tendency is to make it a little more proximal, and then you'll run into trouble. So those are a couple of technical things about the osteotomy which one has to be careful of when you're doing it. Otherwise, you end up taking too little or too much bone, and then you have the same problem again. Okay.
John,
Thank you.
I haven't done it, but from my understanding is you remove the physial part of the.
Yeah, that's what. So it should be more
So you get bone on
proximal
bone
than in the. You tend to go more into the neck side than onto the head side. You need to be more on the head side than you would normally tend to be.
Yeah, and one more
But generally
point.
that is not a problem because the
It's
physis
not a
is
problem,
quite
but for the
easily-
late ones, it is when it's
Yeah,
already.
where it is already.
Coming back to the same question, Dr. Gupta, you were saying something. Do you do trochanteric physiodesis for various osteotomies?
It's actually a plate, not a
Yeah, a plate.
do a
Yeah.
cases, but initial cases I have not done. But I have seen that more than 9 or 10 years, trochanteric overgrowth is not a big issue. Less than that, it's.
But Matthew O'Leary's, Benjamin Joseph
Does-
recommends putting a
He does
Screw
for
through
every
it.
case.
Yeah, I always do, but I don't know whether.
Well, actually, if you go by the principle of Waters and growth modulation, what is recommended that you put, and that's what he used to show us when he came last year.
That's right. That's right. Any more questions, sir? Anybody would like to comment? Thank you, Dr. Vaidya.
Well, thank you, chairpersons. Great job indeed. And now I would request Dr. Sandeep Vaidya to chair the next session. Which will be on fractures, first on the upper limb, and then we're going to follow it with the fractures of the lower limb.
Okay, so this session is now on the fractures of the upper limb, and I invite the first speaker, Dr. P.N. Gupta, and he is going to speak on what are the acceptable criteria in pediatric upper limb fractures. Okay.
Which one is that?
getting the, meanwhile they're getting the talk loaded into this particular computer. So it's a, no, this is not the one. I'll put it on my pen drive. Just label P.N. Gupta lecture. Lecture. I put it in the desktop. Yeah, okay. So, good afternoon everybody. I've been asked to speak on what is acceptable in pediatric upper limb fractures. Well, pediatric upper limb fractures, basically if you see what is acceptable, what is not acceptable, it's actually a very big talk and you can talk for a full 5 to 6 hours. But what I have chosen is the acceptable management norms for forearm common fractures, which are the forearm fractures and the distal radius fractures, because these are the fractures which have maximum confusion as far as the management part is concerned. So first we talk of forearm fractures. There is a controversy whether to do a closed reduction or a open reduction, and if open reduction, then which implant to choose and at what age group. And then second big controversy is what should be the position of immobilization as regards to the pronation supination. And then third is how much malunion in forearm is acceptable in children. So there is a debate. Conservative people say that there is no infection risk. However, the cons are that it may not be anatomical reduction, there may be a slip of reduction, or the operative one says that it's an anatomical reduction, early return to activity. However, there is a risk of infection. However, if you see this paper by Jones et al. In 1999, which they say that conservative management is still the gold standard of treatment, especially in the younger age group. But there are problems with non-anatomical reduction, including rotation, angulation, bayonet apposition, or overriding. So we know that the distal end of the forearm bones, that's the radius and the ulna, they are the growing ends and they remodel, and the fractures near to that remodel. But the fractures which are in rotation basically never remodels. So what should be the position of immobilization? We know that the radial styloid is actually opposite to the tuberosity of the radius. So that will guide you with the position. So there are numerous ways to see that. This is a diagram which shows that if the forearm is in supination and the tuberosity would be towards the ulnar side, and similarly if the forearm is in pronation, the tuberosity would be away from the ulnar side, and similarly the mid-prone. But there was a landmark paper by Wright et al. Where they described a radius crossover sign, which says that if you take X-ray in pronation, the radius and ulna, they cross over in the proximal and middle third junction, whereas they cross over somewhere in the middle and lower third junction if it is in mid-prone, and if the X-ray is taken in full supination, both the bones, they will not cross over on the X-rays. So depending on the position of the proximal fragment, the distal fragment is to be aligned. The traditional teaching is that proximal forearm fractures you align in supination because the pull of the supinator, mid forearm you try to align it in mid prone, and distal forearm you align it in pronation. But if you see this, the crossover is on the proximal third. So this fracture has to be immobilized in pronation. Other thing is you can take the normal limb radiographs and compare the two sides. What about the angulation? There was a cadaveric study done in 1982, way back in 1982, where they said that angulation less than 10 degrees is hardly associated with a loss of motion. But angulation of 20 to 30 degrees or more causes a significant loss of pronation and supination, and this loss actually, if you see, is more if the fracture is more proximal, if the angulation is more proximal. So this was a study in 79 where angulation less than 10 degrees, age less than 8 years, and fractures in the age more than 8 years, angulation more than 10 degrees, and fractures in the proximal forearm, they were associated with loss of pronation and supination. The same study which was corroborated by the cadaveric studies. What about the bayonet apposition? That means a end-to-end, a little off apposition. Bayonet apposition actually does not interfere with function, but a complete displacement with angulation and malrotation, if you see like this, they have an additive effect. So that should be taken care of. So what sort of mal reduction is acceptable? 10 degrees in the proximal third, 15 degrees angulation in the mid third, and 20 degrees in the distal third, especially if the age is less than 8 years. And if the age is more than 8 years, then the potential for remodeling becomes less and less. And rotations, minimal rotations are to be accepted. What about the redisplacement in plaster? Well, loss of reduction could be seen as to the tune of about 15% in younger children and more than 60% in older children. And what are the fractures which actually have tendency for redisplacement are the ones where anatomical reduction is not achieved and they are inherently unstable. So fractures like this, segmental fractures, inherently unstable fractures, basically they are indications for primary internal fixation. So primary internal fixation is basically done in unstable fractures, failed closed reductions, open injuries, and older child. So what's the hardware choice? K-wires, elastic nails, or intramedullary implants in the younger child. Plate and screws is usually preferred in the adolescent age group. So carry-on message for forearm fractures is closed reduction, still the gold standard in younger children. Failed closed reduction, open reduction, or internal fixation with IM rods or older child, internal fixation with plate and screws. So second is distal radius fractures. So distal radius fractures can be divided into metaphyseal type, physeal fractures, or Galeazzi type fractures. So there is a lot of confusion in the management. So I'll try to clear that confusion. So metaphyseal fractures with angulation less than 10 degrees or less than 1 centimeter of shortening usually tend to remodel by 12 months. Remember, the distal end of radius is the growing end and it tends to remodel. So all these fractures can be immobilized without closed reduction in a support. Metaphyseal fractures, Salter-Harris type 1 and 2, if angulated more than 15 degrees, then closed reduction and a cast is usually the accepted norm. And out of that, about 1/3 may displace. So closed follow-up of these cases with repeated check X-rays or weekly monitoring for at least 3 weeks is desirable. Angulation more than 30 degrees, displacement more than 50%, or a volar displacement makes a highly unstable situation. So these fractures like this, they are preferably done with a closed reduction and pinning. Salter-Harris type 3 and 4 fractures are uncommon. However, if they occur, they should be anatomically reduced and fixed with K-wires. Where do we see loss of reduction? In isolated, displaced, usually more than 30 degrees angulation of the radius fractures or volar displaced fractures. So how much malunion is acceptable? It actually depends on the age of the child, and if you see the remodeling occurs at about 0.8 degrees or roughly 1 degrees per month in a growing child. So if there is adequate growth remaining is there, the remodeling tend to occur. Distal radius malunion in adolescence, the growth remaining is very less, the remodeling potential is very less, so it does not remodel, so it's preferably fixed internally. Galeazzi fractures is more often a variant rather than a classical one, which includes a fracture of the distal radius with separation of the distal ulnar physis. So it's dorsal and volar. Dorsal is distal fragment supinated and volar is distal fragment pronated. So principles of management of Galeazzi fractures in children are: you reverse the deformity But if overriding is there, plate fixation should be the accepted norm, or grossly angulated, or fractures presenting near to the adolescence. Plate fixation is the accepted norm, and if distal ulnar physis is unstable, it should be fixed with a K-wire. So carry-on message is that most children with distal radius fractures can be managed with closed reduction. However, the unstable ones with more than 30 degrees of angulation or the volarly displaced should preferably be fixed in the primary instance. And younger the child, more the remodeling potential, and beware of the growth rest. So summary and conclusion is that no single yardstick can be applied to fractures of the forearm and the distal radius. Management should be based on how much the fracture is unstable and the personality of the fracture. One must remember that the fractures near to the growing ends, they tend to remodel, especially in children younger than 8 years of age, and internally fix all the unstable ones. Thank you so much. Yeah.
Does your treatment decision making change depending on whether it is in a distal radius, whether it is an isolated radius fracture or it is a combined radius and ulnar fracture? Would you be more aggressive in an isolated radius fracture because that is a more unstable?
That's a more unstable. I would be more aggressive in isolated distal radius fracture, yes.
So you would probably tend towards K-wire pinning?
Yeah, tend to internal fixation with pinning, yes.
Okay. And another point you said is, pin the distal ulnar physis.
If unstable.
Now that is something, because don't you risk growth plate arrest?
Is quite high in distal ulnar physis. Okay. It's quite high in case about 1/3 of them, they may end up in a growth plate arrest. With the distal ulnar physis.
But despite that, you may proceed with pinning.
If it is unstable, in a Galeazzi-like situation.
Okay.
Even in distal radius, when you pass through the physis, then there are also chances of growth arrest are there?
If you are using a very small pin, very thin pins, usually 1.5 mm K wire, the chances are almost negligible, you can say.
You have to pass through the physis?
Yes, you have to pass through the physis. Most of the times you have to pass through the physis, yes.
Additionally, one point I would like to make that your attempt at passing the pin, it should be a single attempt. So take your own time, decide the direction of your pin beforehand, before making the actual entry. Because multiple entries, there is a more risk of damaging the growth plate.
What you do, keep the wires out or close it? What the preference is?
Both have their pros and cons. If you keep the wires out, basically you have to protect the wires. And if you push the wires in, then you don't need to actually do a dressing and all. It's your choice. If you feel the child is very young and the fracture will heal in a small amount of time, maybe 3-4 weeks, then you tend to keep the wires out. Otherwise, you tend to put them in. It's your choice actually. Your choice.
Second surgery is avoided.
It's your choice. That's what. But if older child, I would perhaps tend to push them in.
Okay, thank you, Dr. Gupta. So we call on the next speaker now, and the next talk is on decision making in missed Montagias by Dr. John Mukhopadhyay.
Well, in the meantime, as you just sit for Dr. John's lecture, please note that we are hosting the POSICON 2015 in Delhi. Those are the venue and the date. So anybody interested over here, I hope this is a big crowd of pediatric orthopods, so they can always join us. Sorry, it's POSI 2015. I said 15. And the next POSI actually is in Chennai, which is in 2014 January 9th, the 10th, starting with the pre-conference workshops. So you're most welcome to join us there as well. For any information on POSI 2014 in the next 1 month, please contact Dr. Vijay Sriram.
Okay, sorry about that. It was loaded in the morning, but it seems to have got lost. I'm going to talk about neglected or missed Monteggia fractures. If you look at Monteggia fractures in general, it's well known that the type 1 fractures are the most frequent. It's interesting that some of them may present without an obvious ulna, as you can see here. If you see the affected side as opposed to the normal side. Now, so you could get malunited fractures either because the lesion has been missed initially, or there's been an inadequate reduction, or there's been a failure of reduction, or failure of maintenance of reduction. So this is not an uncommon scenario where a Monteggia fracture has been reduced adequately, looks good, but 10 days down the line, you can see that the radial bow of the ulna has recurred and the radial head has displaced again. So today we tend to be a little more aggressive in fixing the Monteggia fracture than was earlier. Why do you treat this neglected or missed Monteggia even if they are asymptomatic? Because long-term follow-up reveals various problems including premature arthritis, pain, instability, loss of pronation and supination, as well as late nerve palsies. And some of the studies which have showed problems in the long term include symptomatic problem in the long term which needed radial head excision, pain, instability and restricted motion, tardy radial nerve palsy reported by Austin. This could be subluxation of the distal radioulnar joint, and you can also get tardy ulnar and median nerve palsies, although this is really very rare but has been reported by Chen et al. In 1992. Now, there are various forms of management which have been advocated for this, starting from leaving them alone to radial head excision. However, if you do this early, it will cause instability, and even late can cause some instability. There's a fascial sling operation such as the Bell-Towse procedure, which we'll talk about. There's the open wedge angulation and ulnar osteotomy with bone graft, or with or without bone graft, again with or without internal fixation. You can have distraction, angulation and fixation, or angulation and gradual lengthening to correct the problem. The basic sort of things that you need to do is to try and correct the ulnar length and angulation, because that is what keeps the head dislocated. You need to reduce the radial head, and then you need to maintain the reduction, whether it's you use open methods or closed methods to get this correct. So what is our usual surgical strategy when we get these patients? We use a posterior incision. Depending on how late is it, you could recreate the fracture or do an osteotomy. Get the length and angulation correct. I think this is key to getting the head reduced stably, because without that the head will never be stable. In late cases, the radial head will require open reduction with excision of all the fibrous tissue along with it, as well as sometimes the annular ligament. And then you have to make a decision as to whether you need to reconstruct the annular ligament, and usually we use the Bell-Towse procedure using the triceps aponeurosis for this. And if necessary, we would use a K-wire fixation for about 3 to 4 weeks to make sure that the head is in position, although there is some controversy about this. So going through some examples, this child presented to us about 6 weeks, and at this stage I think it's still possible to recreate the fracture, get the ulnar back to its correct length, fix it adequately, and usually up to about 3 months we've seen that you do not need to do an open reduction of the head. If you can get the ulnar back to right length and angulation, the head falls back into place. Up to 3 months more or less all the time. This is a 2-year follow-up on this patient, and you can see he's got good function, good movement, and no restriction at this stage. As it goes later, the problems increase. Here was a 9-month-old injury. Again, the same procedure. We needed to do an open reduction of the head to get rid of all the fibrous tissue there. Angulation osteotomy of the ulna, which was fixed with a plate. And here the head was stable without any further procedure. So that was all we did. And then again, this is the follow-up of this patient at about 9 months down the road. He's got good movement and good function. As you get, some of these will not be stable in spite of what you've think you've done an adequate reduction. In this case, it was again another example. You can see the slightly over-angulation of the ulna, but you get a good stable reduction of the radius if you can achieve this adequately. As you get later down the line, this is a patient who presented 1 year after the injury, and here we went through the same sort of steps of treatment. You did the angulation osteotomy, you did the open reduction, but it was still not completely stable. So we did the Bell-Tow's reconstruction using the triceps aponeurosis. So you can see that this pointer is not working, is it? Okay, wrong side. So there's the fascial sling being taken, and it's tied around the radius here so that the radius is in place. And in this instance, we also used a pin to make sure that the head had not displaced, although it was reasonably stable. But you can see again, this is taken out at 3 weeks. This is a 1 year post-op picture, and again, a good function. This 15-year-old presented actually initially with a fixator on for an open injury. That was the position she came to us about 3 months after the injury, and here we used the pin through the radius into the ulna. I'm not sure if there's any particular advantage of it, but at that time there was a lot of thing about not putting it through the capitellar head into the radial head, so we used this, and this did reasonably well as well. So our results using it through the capitulum has not been too much of a problem. As long as you use a reasonably thick pin, make sure you do it, put the cast on yourself, and when you're removing it, do it yourself. Don't leave it to a junior person to do these parts of the procedure. And this is the follow-up on this patient. Again, head is well placed and the position is maintained. Now this is one of those patients where we may have stretched a bit too far. This was a 13-year-old and a 6-year-old Montagia. Now this is a situation where maybe just excision would be the best way to treat it. We decided to go ahead and reconstruct it. We did again the same procedures, angulation osteotomy, Bell-Tow's reconstruction, K-wire to hold it in place, and everything went off. We managed to do the surgery well, but if you look at the radial head in this, where is it? Yeah, you can see that's already misshapen to some extent, and you can see that on the X-ray as well. But interestingly, over a period of time, the head has kind of got its shape back. The only problem this patient had was posterior intraosseous palsy. Now if you see over, this is at about 1.5 years, how the radial head has reformed as compared to this in the earlier X-ray where it looks very flattened. But it's got back to its shape, he's got back movement, and luckily he recovered his posterior intraosseous nerve palsy. But that is a risk you take if you're doing it very late. The other methods are the external fixation. This is a case courtesy Dr. Slongo, where you use the external fixation and not do an open reduction. And you can do the gradual distraction angulation, and proponents of these claim that you can get the radial head reduced without having to do an open reduction. We've done one of these. I think I was a reasonably good result, but I'm still not fully sort of confident that I'd be able to get the radial head back each time. After 3 years, there's an issue of congruency of the radial humeral reduction, and you have a higher complication rate as reported in the literature. So here's a situation where it may be worth waiting if the child is over 12 to go for a radial head excision. Thank you.
The questions, I think we have some time for panel discussion later on, so we'll take that later. And next I call upon Dr. Sanjay Sarup, and he will speak on pinning for type 2 supracondylar fractures.
Thank you. Thank you, ladies and gentlemen. This was supposed to be a kind of a debate on whether type 2 supracondylar fractures need pinning or not. So I guess what we'll do is we'll ask the house, there are some components to it. One is that it is extended but not fully translated. There is some cortical contact, and the anterior humeral line does not transect the capitulum. And there is a posterior and a rotational displacement in these fractures. There is some medial impaction. and there is some varus angulation. So all of these constitute a typical type 2 Gartland supracondylar fracture. Now how many would like to pin it now? Yeah, so that's the problem. When we look at a type 2 supracondylar fracture, in our mind we think there is a break in the front, there is an extension, that's it, we'll push it back, it'll be fine. This is a very blurred picture, but it shows some comminution of the cortex, which you may find in some of the cases. The other thing is, what is the reliability of the classification? When you say type 2, is it really a type 2? Is type 1 really a type 1? Is type 3 really a type 3? And we have a gentleman called Mallow, and in 2010, he studied radiographs of 72 supracondylar fracture humeri, and he got them assessed by 4 pediatric orthopedic surgeons. And there was full agreement on type 3 because it's obvious to everybody that's type 3. But there was only moderate agreement on type 2. People did not agree. Some people thought it's 3, some people thought it's 2. So there is some confusion there. So I think type 2 is a spectrum of injury. It's not just a simple extension type of a situation. There is another issue here now. Look at this video. Will it work? Look at this guy's tibia. There. Did you see the amount of angulation and displacement? But when he lies down, his leg is straight. And we see that time and time again in all the sports injuries videos. When the leg breaks, it goes all the way and then it comes back. When it comes to you in the casualty, the leg is relatively straight and the displacement has gone back because soft tissues are elastic and they've jumped back. I'll show you this again, just for, look at this. There he falls, there, and look, it doesn't look too bad now. And that's how you'll get him in the casualty. So when you look at a type 2 supracondylar fracture in your casualty, you have to remember that it has gone more, and then come back by the time you've seen it. So that's another point. Now, then I looked at the experiences of people with conservative treatment of supracondylar fractures, because that's the big thing. With supracondylar fractures, we are mainly worried about cubitus varus. Of course, we are worried about neurovascular things and other things, but mainly we are worried in the long term about cubitus varus. And this is a study by Parikh in 2004, and it's from Journal of Pediatric Orthopedics, and he had loss of reduction in 28%. He had delayed surgery in 20%, and he had unsatisfactory results eventually in 8%, in whom probably they did not do surgery. So, and there is another guy called Fitzgibbons. In 2011 in JPO, he studied 61 type 2 supracondylar fractures, and he found that there was failure of close reduction in casting in 20%. That's pretty high for a supracondylar fracture. Then there was this paper by Spencer. He studied 259 type 2 supracondylar fractures, and there was loss of reduction in 39 cases out of 259. And surgery was required in 42% of the cases eventually. So, patients with rotational deformity, coronal malalignment, significant extension will fail close reduction and casting. That was his impression. Then there was another guy called Moreda, and he published in JBJS in 2013. When he carefully looked at his 46 type 2 supracondylar fractures, he found that mild cubitus varus and mild hyperextension was present in many cases, and 26% showed late cubitus varus, which was quite a surprise because I'm not aware that once it heals, why should you get late cubitus varus? But that was his finding. Lucas et al., he studied 29 type 2 displaced supracondylar fractures treated with close reduction and casting. His failure rate was 48%. So two things come out of it. That natural history of a type 2 supracondylar fracture is not benign, and it is a spectrum injury. So you can get a very mild case to a case which will really fool you, and if you just think of doing close reduction and casting in these cases, you will fail once out of every 5 times. Once out of every 5 times. So what are we thinking of then? This is a typical type 2 supracondylar fracture, looks a bit harmless, but I pin them, so again, just to emphasize that the natural history of this fracture is not benign. Then I looked at experiences with pinning. Skaggs produced a paper in 2004 in JBJS, and he studied 189 type 2 supracondylar fractures. He treated them with close reduction and pin fixation. Loss of reduction 0, cubitus varus 0, nerve palsy post-op 0. He had 4 cases of pin tract infection. But they all healed and the kids did well. So, what are the guidelines now? 2008 OMID, pin fixation for even minimally displaced supracondylar fracture. These guys say close reduction and immobilization is associated with significant percentage of early and late complications, including VIC and cubitus varus. Today, American Academy of Orthopedic Surgeons says that you have to reduce and pin type 2s because improved critical outcomes combined with decreased risk of limb-threatening ischemia outweighs the risks of complications from pinning. I hope. Thank you. Thank you, sir. This is just a picture to show you the other end of the supracondylar fracture, what happens in some of the cases.
Okay, thank you, Dr. Sanjay.
Thank you.
And we'll take the questions in the panel discussion session. So next I will call upon Dr. Vijay Sriram, and he is going to speak on pinning for type 3 supracondylar fractures.
ये किसका हाँ नो नो ये नहीं आई लोडेड इट नाउ नो अभी लोड किया ना अभी किया इट्स नॉट लोडेड